Routine medical checkups are supposed to keep you safe. But there is a question worth considering. What if certain tests after the age of 70 bring more risk than benefit? This is about 5 common medical screenings that may no longer provide clear value for some older adults and why the balance of risk changes with age. It also explores how avoiding unnecessary procedures may help protect health and independence. Imagine being 74 years old. You feel fine, sleep is steady, energy is acceptable. Life still feels normal and active. You go in for a standard annual visit. Nothing unusual. The physician reviews your records and suggests running a few routine tests, just to be safe. Weeks later, you are no longer simply a healthy patient in a routine check. Instead, you are sitting in a surgical consultation. Not because you were sick, but because those precautionary tests revealed something. That finding triggered a sequence of follow-up actions your body at 74 may struggle to handle. And suddenly, the life that once felt stable begins to change in unexpected ways. Situations like this are reported more often than many discussions in healthcare openly acknowledge. The data behind it raises important questions. This perspective focuses on adults over 60 and how medical evidence applies differently at older ages. It is based on medical literature and observed outcomes when care becomes routine rather than individualized. The key idea is that after age 70, some common screening tests can produce more harm than benefit, not because medicine is failing, but because the risk-to-benefit balance shifts significantly with age, and that calculation is not always explicitly discussed during short clinical visits. One important concept helps explain this. It is called the longevity lens. At around age 50, screening often works very effectively. Detect a problem early, treat it, and potentially extend healthy life by decades. The trade-off is usually worthwhile, and the calculation is straightforward. After 70, however, the situation changes in 3 major ways. First, many conditions found through routine screening in older adults may never progress to cause harm. They develop slowly, produce no symptoms, and may never affect lifespan. But once a result appears on a medical report, the system rarely offers a monitor-only approach. Action is often taken. Second, tolerance for medical intervention declines with age. A procedure that a 55-year-old might recover from in weeks can lead to long recovery periods, complications, or loss of independence in someone in their late 70s. Third, there is a cascade effect. One small abnormal finding leads to additional scans. Those scans lead to biopsies. Biopsies lead to procedures. Procedures may lead to complications. A healthy person can end up facing a serious medical burden that began with a precautionary test. This is the core of the longevity lens. Understanding how each step in a medical chain carries increasing risk as age increases. Checkup number 1 involves routine colonoscopy after age 75. Consider the case of Dorothy. She was 77 years old and retired from library work in rural Tennessee. Her previous colonoscopies in her 50s and 60s were completely normal. No polyps, no family history of colon cancer, and no symptoms. A new primary care physician reviewed her chart and recommended another screening. She was hesitant but agreed. The preparation required a strong liquid solution the night before to clear the intestines. It affected her body severely. By the next morning, she became confused, weak, and dizzy. Her daughter brought her to emergency care before the procedure even happened. She was found to be severely dehydrated, with dangerously low electrolyte levels that placed her heart at risk. She remained in hospital care for 4 days. The procedure itself never occurred, and in hindsight, it may not have been necessary. Guidelines from the United States Preventive Services Task Force recommend against routine colon cancer screening for average-risk adults over 75. Evidence suggests that after this age, for individuals without symptoms, family history, or prior findings, potential harms may outweigh benefits. Risks are real. One example is bowel perforation, a tear in the colon, which occurs in roughly 1 out of every 500 colonoscopies. In younger patients, this may be manageable. In older adults, it can lead to emergency surgery, colostomy, prolonged hospitalization, and long-term loss of function. At the same time, many colon cancers found in asymptomatic older adults grow slowly enough that they may never impact lifespan. For some cases, alternative approaches such as non-invasive stool-based screening like Cologuard or annual FIT testing are considered lower-risk options. Symptoms such as blood in stool or sudden bowel habit changes change the situation entirely and require medical evaluation. Checkup number 2 begins next, focusing on aggressive PSA prostate testing and routine mammography in low-risk individuals. Cancer screening should not be misunderstood. It has saved countless lives and remains important in many cases. The issue is not screening itself. The concern is what happens when it is applied aggressively after the age of 75 in people who have average risk and no symptoms. At this stage, overdiagnosis becomes a real problem, and it directly feeds into overtreatment. To explain it simply, modern imaging tools are extremely sensitive. They can detect very small tumors that grow so slowly they may never become dangerous. Some of these growths would stay harmless for a lifetime. A person could live and die without ever knowing they existed. However, once a scan labels something as malignant, the medical system responds immediately. Further testing begins. Specialists get involved. Treatment plans are created. All of this progresses even when the detected cancer may not pose a real threat. Take a situation like Richard's, a 79-year-old former mechanic from Georgia. He remained active, mentally sharp, and continued weekend fishing. A routine PSA test showed a mild elevation. A biopsy followed and identified a slow-developing, low-grade prostate cancer. His doctor recommended radiation treatment, and he accepted the plan. After therapy, his condition changed significantly. He experienced ongoing fatigue and urinary difficulties, and his overall quality of life declined in a noticeable way. Cases like this appear in medical records and research discussions. In hindsight, some patients realize the condition may never have caused harm during their natural lifespan, especially given their age at diagnosis. Research published in journals such as the New England Journal of Medicine has reported that a large share of breast cancer findings in women over 70 are clinically insignificant. In these situations, treatment does not improve survival, but still exposes patients to side effects. The important takeaway is not to avoid all screening. It is to understand personal risk. If there is genetic predisposition, family history, or symptoms, screening decisions change. For average-risk individuals without symptoms, a direct discussion with a physician is essential. Questions such as what treatment would realistically look like at an advanced age can significantly shift medical decision-making. Another area of concern is routine cardiac stress testing in people without symptoms. At first glance, it appears reasonable. A patient in their 70s undergoes a treadmill test or receives medication that stresses the heart while being monitored. The issue arises from accuracy. In asymptomatic populations, these tests can produce a high rate of incorrect positive results, sometimes approaching or exceeding 40%, depending on the group being studied. This leads to further testing, often a cardiac catheterization. That procedure involves inserting a thin tube through blood vessels and guiding it into the heart. Although commonly performed, it carries risks such as bleeding, vessel injury, rhythm disturbances, and in rare situations, triggering cardiac events. If a partial blockage is found, which is common in older adults even without symptoms, the next step is often a stent. However, major clinical evidence, including findings from the ischemia trial, has shown that in stable coronary disease, stents do not significantly reduce heart attacks or extend life when compared with medication and lifestyle management. This creates a chain reaction. A healthy person can move from feeling normal to undergoing invasive procedures and long-term medication without clear improvement in outcomes compared to conservative care. A more effective approach in many cases is focusing on measurable risk factors such as blood pressure, cholesterol, glucose control, physical activity, and sleep quality. Bone health screening is another area where automatic treatment pathways deserve attention. A DEXA scan identifies reduced bone density. This often leads to prescriptions such as bisphosphonate medications, including alendronate or risdronate. While these drugs can help reduce fracture risk, long-term use has been associated with rare but serious complications. One is atypical fractures of the femur, where stress fractures occur in the thigh bone without significant trauma. These injuries can require surgical intervention. Another is osteonecrosis of the jaw, a condition where jawbone tissue begins to deteriorate and becomes difficult to treat. At the same time, evidence shows that the strongest protection against fractures in older adults is not medication alone. It is fall prevention. This includes balance-focused exercise such as Tai Chi, which has been shown to reduce fall risk by nearly 50%. It also includes removing hazards at home, installing safety supports, reviewing medications that cause dizziness, maintaining vision health, and ensuring adequate intake of protein and vitamin D. These combined lifestyle measures often provide substantial protection against fractures without introducing medication-related side effects. This does not mean medication for bone health should be avoided entirely. There are clear situations where it is necessary. Patients who have already suffered fractures, those with very low T-scores, or individuals with strong risk indicators may genuinely benefit from treatment. However, applying a routine DEXA scan followed by automatic long-term medication for an active 74-year-old who has never experienced a fracture and is otherwise in good health is something that deserves discussion rather than automatic acceptance. Before starting medication, it is important to have a clear conversation with a physician. One key step is reviewing personal fall risk factors and comparing expected fracture reduction from medication against a structured fall prevention approach. A simple question can reshape the discussion. What is the real reduction in fracture risk from this drug, compared to a focused program designed to prevent falls? If you have followed this far, take a moment to note your engagement and reflect on these ideas as they apply to your own care decisions. The next topic is asymptomatic carotid artery ultrasound screening. This is one of the least discussed but potentially most impactful screening practices. A carotid ultrasound examines the major arteries in the neck that supply blood to the brain. The intention is straightforward. If a serious blockage is found, it can be surgically removed to reduce stroke risk. On the surface, this appears logical. In reality, for people without symptoms, the situation is more complex and may introduce greater danger than benefit. The surgical procedure used to treat carotid narrowing, known as carotid endarterectomy, carries a stroke risk of approximately 2 to 3% during or immediately after surgery. In older individuals or those with other health conditions, this risk can be even higher. Guidelines from the United States Preventive Services Task Force clearly advise against routine carotid artery screening in adults who do not show symptoms. This includes no prior mini-strokes, no vision loss episodes, and no neurological warning signs. Their evaluation concludes that in asymptomatic individuals, the potential harm from intervention exceeds the expected benefit. The reason is that many older adults naturally develop some narrowing in these arteries over time. These changes are often stable and do not cause symptoms. Routine screening may detect these findings and lead to a recommendation for surgery. However, intervening on a condition that was never causing problems can introduce risk. In some cases, small fragments of plaque can become dislodged during surgery and travel to the brain, creating the very outcome the procedure aimed to prevent. Because of the consistency of these findings in medical literature, individual case stories are not necessary to understand the broader pattern. The data already shows that some patients move from routine screening into a completely different medical path due to intervention rather than disease progression. For individuals without neurological symptoms, such as sudden vision changes, facial weakness, limb weakness, or abrupt severe headaches, routine carotid ultrasound is generally not recommended. A more effective strategy focuses on modifiable risk factors. High blood pressure remains the strongest contributor to stroke risk. Blood sugar control, smoking cessation, management of heart rhythm disorders like atrial fibrillation, and maintaining physical activity all play a larger role in prevention. If any neurological symptoms appear, even if brief and resolved, immediate evaluation is essential. That changes the clinical picture entirely. To support better decision-making, There is a practical framework known as the 5-question protocol. Before agreeing to any screening test, especially for individuals over 70 who feel well, it is helpful to consider 5 specific questions. The first question is about the likelihood of false positives in people of similar age. This helps determine how often a test may lead to unnecessary follow-up procedures. The second question asks what realistic treatment options would be available if something were found at your age and health status. This shifts focus from detection to actual outcomes. The third question examines the risk associated with any procedure that might follow. Every intervention carries risk, and it should be clearly understood in advance. The fourth question considers what would happen if the finding were monitored instead of treated immediately. In many cases, observation with periodic checks is a valid and sometimes better approach. The fifth question asks what non-invasive strategies exist for managing the condition. In many areas such as heart health, bone strength, and stroke prevention, lifestyle changes and medication can provide strong results with fewer risks than procedures. Most well-informed physicians will respond positively to these questions. They are part of a thoughtful decision-making process. If a healthcare provider reacts negatively or dismisses these concerns, that response itself provides meaningful information about whether that provider is the right fit for your care. There is an important distinction in modern medicine. One approach focuses on identifying every possible abnormality. Another focuses on improving quality of life and maintaining independence. After 70, healthcare should prioritize living well, rather than generating excessive findings. The best medical decisions often require restraint. Choosing not to act immediately can sometimes require more judgment than proceeding with a test or procedure. Patients have the right to understand what each test is designed to detect. They also have the right to know what will happen if something is found, and whether treatment would truly improve long-term health and independence. Modern medicine offers powerful tools, but their value depends on how and when they are used. The goal is not more testing. The goal is better outcomes aligned with personal health priorities. If this message has provided a clearer perspective on health decisions after 70, consider following for more content focused on practical and evidence-based medical insights. Your engagement and reflection on these ideas help continue this conversation about making informed choices in healthcare. Please leave your thoughts about this content in the comments below. Thanks for watching. See you in the next one.